Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
The principles and materials utilized in the physiological basis for removable appliances are dictated by the health and function of the oral tissues. The purpose of this presentation is to present the principles involved in taking a stable impression and demonstrate the use of materials that will accomplish this goal. The selection of the materials used in this demonstration is based on the normal functional requirements of the oral tissues. One of the main objectives of a removable appliance is to restore the occlusal support. The main reason for putting the appliances in the mouth is to help support the occlusion. In order to do this, we must have a stable base, and this is the key to this impression procedure. To have a stable base, we must have intimate tissue contact between the base and the tissues, both when the tissues are at rest and when the tissues are in function. So the stable base comes from intimate contact of the base with the tissue when the tissues are at rest and in function. If we have intimate contact with the base with the tissue, we have the maximum situation for our retention, which comes from our interfacial surface tension, where we have two close approximating surfaces and a thin film of fluid in between. If we have this situation, we have stability. If we have stability, then we have retention. So our entire basis of this procedure is to establish stability. We don't worry about retention, because if we have stability, we will have retention. So our paramount goal is to have a stable base, and then if we have a stable base, we will have a base with retention. The first phase of establishing a stable base is to record a stable impression. The purpose of the impression is to fit the base to the patient's individual and peculiar ridge form. Our objective then is to record the tissue in a healthy condition and in a semi-dried state. The first phase in preparing the patient is to allow the tissues to assume a normal, healthy condition. In doing this, if the patient is wearing an old appliance, this appliance must be left out of the mouth for approximately 72 hours or until the tissue has lost all the inflammation. If there's inflammation there, there is swelling, we should leave the appliance out a sufficient amount of time to allow all the inflammation to leave the tissue. Also, we would want to leave the appliance out, especially if it's an ill-fitting or unstable appliance, because the appliance can distort the tissue. We would want to allow the tissue to come back to its normal resting form before we took the impression. So it's important to establish the healthy tissue before we take the impression. So we want those tissues, supporting tissues, as near a normal condition as we can. Would you roll your head this way a little bit? Make sure that there's no injury to the tissue, no inflammation to any of the ridge tissues or peripheral tissues. Would you roll your head that way, please? This is a difficult ridge to work with. We have very little ridge there. The tissue attachment of the peripheral tissues is way up on the ridge, and we can wind up with a very distorted impression here. So the first step in preparing the mouth for the impression would be to leave the old appliance out and allow the tissue to come back to as normal condition as we can. In preparation for the impression, we would also want to dry the tissue somewhat. Our goal is to take an impression of a semi-dried, healthy ridge to get the mouth and the tissues in a semi-dried condition. We premedicate with an antisialagogue The one we use is atropine sulfate. Atropine sulfate, 1/150th of a grain. The patient takes 3 tablets. 1 tablet 3 hours before the appointment, 1 tablet 1 hour before the appointment, and 1 tablet 2 hours before the appointment. By the time the patient gets in, the tissue should be to the semi-dried condition. The way to tell whether the tissues are in a semi-dried condition, the tissues look somewhat like a street in the fog, where you have a thin layer of moisture covering everything. There's a glistening appearance to the tissue. If you look around the areas of the tissue, you'll see little beads of saliva that are balled up, as we have here. Now, if the patient is allowed to sit without swallowing, you'll get a pooling of saliva in the ridge area, particularly in this patient. And that's why you would want to check the mouth, make sure there's no pools of saliva before you place the impression material. But the appearance of this tissue, as you see here, glistening appearance, little beads of saliva around the periphery, indicates that this patient is dried to about the right amount we would like. We want a semi-dried condition. Some of the other anti-sialagogues tend to dry the mouth out too much. If the impression material takes longer than another hour, then the patient can be given another tablet. So we want the mouth in a semi-dried condition. One of the factors in establishing retention for our removable appliance is the interfacial surface tension. Interfacial surface tension comes from the close approximation of 2 surfaces, and we can liken the appliance on the ridge to these 2 glass slabs. If this represents the ridge and this represents the appliance, our objective is to get these to fit as closely together as we can. Glass slabs or glass plates placed together give us a simulation of this. However, we can see here we lack retention, or these 2 slabs won't hold together because they're both dry. So we would like a thin film of fluid between these plates. If we put a thin film of fluid, just put a couple drops of water on this plate, representing what we've done in the mouth, give us a semi-dried condition, we will see that we have got a lot of retention. We can lift that lower slab with that thin film of fluid. So therefore, we do not want to dry the mouth out completely. We want to have a semi-dried condition. Then we have our maximum. I can't pull the plates apart without a lot of force. So this is the purpose of the semi-dried condition. The objectives of the impression was first to get the tissues in a normal, healthy condition. And then we want to record all the minute details in the tissue without distorting the ridge tissue or without distorting the peripheral tissues. And this would be the objectives of this impression procedure. The tissues of the mouth and the ridge area are not smooth. There's lots of little wrinkles and irregularities in the tissues. The object of this impression procedure is to pick up all these little minute details in the impression material with a free-flowing impression material. And we would have these recorded in our impression. And as you can see here, these little wrinkles, irregularities in the ridge tissue that we recorded, and we want to make a base that would fit these irregularities. Frequently, we use an impression material that does not record these details, and we wind up with a base that is void of these details. If we look at a graphic representation of this, we would find that the base at rest would fit on these top of these irregularities and would not be an accurate fit of the ridge area. So the consequence of this would be is when we use this base under function. If we make a base from an impression that doesn't record details, and we place it in the mouth. When the base is at rest, we would find that the base would rest on the tops of the tissue, which is represented by the green area in this diagram. We have lots of voids in here, and the base is resting on the tissue. Every base, regardless of the impression technique, becomes stable during function as soon as uniform contact with the tissue occurs. However, this functional position is different than the base position at rest. The water-filled and living tissue has elastic properties. Anything that is both elastic and alive will refuse to remain in a distorted position. Instead, the tissue will fight to regain and maintain its normal form. When the functional force is released, the tissue would tend to return to the normal or rest position. So with a base of this nature, we have two positions, a functional position and a rest position. The objective of this impression is also to record the tissue in an undistorted condition. If we were to apply force over the ridge, we could distort that tissue. If we distort the tissue, we find that the crest of the tissue is blunted over and the tissue would bulge out around this distortion. So if we have a material that has less resistance to flow than the tissues, if it touched the ridge first, we would have a distorted position of that ridge, or we would distort the crest of the ridge. If we made a base that fit this, at rest, the base would rest on the top of the undistorted tissues, and there would be voids where the ridge area was distorted, so that as we would put this base into function, it would move because it would be resting on the tissues, and it would have to distort the tissue in function in order to be a stable base. During function, the tissue is forced to fit the base. Once the functional force is released, the distorted tissue succeeds in lifting the base out of uniform contact, and the base becomes ill-fitting again. This movement can present a problem. If we have movement, we can have a rubbing of the base against the tissues. This rubbing of the base against the tissues can cause sore spots. Generally, what happens if we have a sore spot, due to this rubbing, we go in here and we relieve the inside of the base. In relieving the inside of the base, we make this base more ill-fitting, and thus we would have more movement. This movement creates a problem, the movement that is present in the conventional partial denture. This movement is difficult to design a stable occlusion. It is also difficult to attach this base to the abutment teeth because of this movement. The rest position of the tissue can be relatively stable. There can be many so-called functional positions of the tissue, depending on the form of the tissue during the time of the impression, the force, and the rigidity of the impression material. If we take an impression of this resting material, and if we have a base that is in intimate contact with the tissue, this means fits the tissue at rest, then the only base movement that can occur during function would be due to the compression of the tissue. The larger the area covered and the more tissue is captured, the less compression can occur. The captured tissue takes on the form and rigidity of the base because the tissue is made up of solids and liquids, mostly liquids. The fluid in the tissues are enclosed in a strong, non-stretching mucous membrane. Therefore, no fluid leakage can occur. The base is stable because this same position exists for function as for rest. The stable base and tissue will make every effort to maintain this position. Whereas if the unstable base is held in contact with the tissue, we could get ridge resorption, with the stable base, the tissue can support comfortably in a natural contented position because the static tissue or the tissue at rest created the impression. So the goal of this procedure is to capture the tissue at rest. In taking the impression, there is much controversy as to where the peripheral tissues should be when we're taking the impression. According to these principles that we're going to use, we try to capture those tissues at rest, or those tissues where they occur, or the positions that they assume around function. As a patient functions in talking and speaking and eating, the tissues are more or less around a certain neutral area. If we look into the mouth, we see that the tongue probably functions near the occlusal surface of the teeth most of the time. If the patient sticks the tongue way out, then the floor of the mouth comes up, or if they stick it way out in the cheek, then the floor of the mouth comes up. But the biggest part of the time, the tongue is right around this neutral position. Now pull your tongue back, please. You notice the floor of the mouth, the changing of those tissues. Bring your tongue forward again, down again. Pull your tongue back, put it up in the roof of your mouth. Notice the different positions that the floor of the mouth, the peripheral edges there, assume with the movement of the tongue. So what position would we want to capture? We'd want to capture that position where the tongue is at rest in the floor of the mouth. So bring your tongue, just let your tongue relax in the floor of the mouth. Now it's hard for him to do that because there are no teeth. But with the impression tray, we'll give him some guide as to where that tongue should be. Now the peripheral tissues around the buccal and labial areas should be at rest when the patient is functioning around this rest position or is at rest. Now open wide, please. Of course, if he opens wide, this pulls the muscles and the tissue in the periphery will come up. But yet this isn't the position that we want to use in taking the impression because the patient only opens wide once or twice during the day, but he functions around this neutral position. So close. We'd want this patient's tissues in a rest position when we take the impression. If we pull on the tissues, put our fingers in the mouth, we can distort this peripheral tissue, as you can see here. Notice the change in the peripheral tissues as we move or manipulate this tissue. So we wouldn't want to have our fingers in the mouth. Also, the size of the tray that we would use would have some effect on this peripheral tissue. If we use a large tray, such as the alginate tray here, we can see how that would distort these peripheral tissues, and the patient cannot bring the teeth together in this rest position. So the size of the tray has a lot to do with the peripheral edges. This is a hydrocolloid impression. Some people seem to think that they can take a hydrocolloid impression and have a stable base, but the size of the tray, water-cooled tray, would prevent us from getting those tissues in the resting position because of the bulky tray that we would have in the mouth. The tray that we would use would be one that would not interfere with the peripheral tissues at rest, so that we can take the tray, place it in the mouth, and the peripheral tissues can assume the rest position. The patient can bring the teeth together and the lips together, and we can take the impression with the tissues at rest. Open, please. Now, if we look more closely at what we can do with this peripheral tissue when we manipulate it, notice this peripheral edge along here. Let's see what happens to that as I manipulate the tissues. Put your head down a little bit, please. As I manipulate the peripheral tissues, we can see that tissue going up and down. Where would we want the peripheral tissues? Well, we'd want those at rest because we can't duplicate this tugging position or pulling position. If we look at a schematic diagram of this, we can see what we are doing to the ridge, the shape of the ridge as we're tugging on the lips. As we pull the lips back, we can distort that tissue way up on the crest of the ridge. As you see here, we can pull those tissues way up and distort the crest, the tissues way up almost to the crest of the ridge. So if we pull on the tissues, we can distort the impression of that ridge. If we take this distorted impression, we pour it up, and then we make a base to fit this distorted position, we can have a base that appears to fit this position quite accurately. If you notice in here, this base can be made to fit this distorted position. We distorted this ridge area, or the tissues, peripheral tissues, part of the way up the ridge. Now, if we see the effect of this, if we let go of the tissues, when this base is placed back in the mouth and the tissues are at rest, you can see what happens to this base. It no longer fits the tissue. The base is not an accurate copy of the ridge. The only time that this base would fit accurately is if we distorted the tissues again. But when the tissue is at rest, this base would not fit the tissues. The purpose of the impression tray is to act as a vehicle to carry the impression material into the mouth. The impression tray in no way dictates the way the impression is formed. The tissues, the resting tissues, are the things that dictate the way the impression is made, and the tray should not interfere. Therefore, it sets certain limitations on the tray. The tray should also give support to the impression material after it's set, so we can place it back into the mouth and check the accuracy and the stability of the impression tray, or the impression. So the impression tray gives support to the impression material. The impression material takes the impression. The tray should not interfere. In order to give support, the tray must be rigid. It should not flex. It should give adequate support. The problem exists in the lower free and saddle impression, where you have a lingual bar area. This should be rigid enough to give rigidity, thick enough to give rigidity, but yet not bulky enough to prevent the normal positioning of the tongue. The impression tray should be lightweight. It should actually float on the material or in the material so that it wouldn't sink to the bottom of the material and touch the tissue. The tray should not touch the tissue at all. The tray should not be bulky so that the tissues can be in their rest position. If the tray is too bulky, it will distort the peripheral tissues. There should be adequate relief under the tray, between the tray and the ridge tissue, to allow the material to flow adequately without the distortion of the tissue. You take a real fluid material and force it into a restricted area, and you will get hydraulic pressures, which could distort the tissue. So the impression tray has certain requirements. We can meet these requirements best for a mandibular tray by using cast aluminum, and this is a cast aluminum mandibular impression tray. This impression tray is made from a model of the mouth. This is an alginate impression from the mouth. It's an overextended impression, so we would like to fabricate a tray from this impression. What we need is a wax pattern for casting the aluminum. We can make this by adapting pink base plate wax directly to this model. We warm a piece of base plate wax and start adapting it to the outline that we penciled on the model. Now, you must recognize that this is an overextended impression, so you want to gauge the extent of your impression. Now, the question continually comes up as to how much relief you should have under the tray. If you want to work with a relief of about 1 thickness of the pink base plate wax that hasn't been thinned out too much would be an adequate relief. But as I'm doing in this case, I'm going to go ahead and adapt this right to the model without a relief and make sure that it doesn't fit the tray or fit the model accurately. So by just adding wax, trimming it away, we would go ahead and form a wax pattern that we can give to the laboratory technician so that it can be cast in aluminum. Things you look for here is you would see that there's relief between the tray and the ridge area. Sufficient relief for the escapement of the impression material from the tray. There's sufficient bulk in the lingual area here so that we get the rigidity we need. Now you can go ahead and use the teeth as stops. As you see here, we've extended the tray up over the occlusal surface, the incisal edges of the teeth, to provide stops for the placement of the tray. In order to position the tray and keep it from touching the ridge tissues, these stops can be useful. So this wax pattern then can be cast in the aluminum material, and we wind up with a cast aluminum tray. And the stops that we would have on the teeth, and the space that we'd have between the ridge tissue and the tray to allow adequate escapement of the material once we place it in the mouth. If you can't use a cast aluminum tray, some of the acrylic materials can be used. This is a vacuum-formed impression tray made of material, the acrylic materials. The problem here again is gaining a rigidity across the lingual bar area. As you see here, we have embedded a heavy wire in the lingual area of this tray. If you're going to use acrylic materials to get rigidity without too much bulk, you're going to need to add a heavy wire in that lingual area. This gives you sufficient strength. So if you can't obtain a cast aluminum tray, an acrylic resin tray properly supported would provide a satisfactory tray. This can best be accomplished from aluminum. A tray that was previously designed and used to take an impression on this patient, you see here. This is another modification to give rigidity. It's carried upon the teeth. We want to come up on the necks of the teeth a little bit so we can get the position of the tissues in relationship to the teeth. Also, make this lingual bar wide all the way around here so that you can carry enough impression material to the mouth. So we have the impression tray. We now go to the mouth, practice with the patient on how to insert the impression tray. Open, please. Put that. Now, the procedure for taking the impression involves certain things that the patient has to do as you place the tray in the mouth. And you should practice with the patient before you take the impression. The tray is seated in the mouth with the impression material on the tray. The tray is held in position. The patient sticks the tongue way out, and then they bring the tongue back slowly to where it rests behind the lingual surfaces of the lower anterior teeth. It fills the floor of the mouth. And then the patient brings the teeth together, close, right down together, and contact, and then the lips would come together and the tissues at rest. There should be no bulging of the tissue, and the peripheral tissues are at rest. Now, with your teeth together, let me go in there and make sure that the occlusion, let me have this, please. Make sure that the posterior teeth, open, please. Make sure that it's closed again now. Turn your head this way just a little bit. Make sure that the opposing teeth do not hit that tray. If they hit. Open, please. Now practice the procedures 2 or 3 times to make sure that you and the patient know what is going to do. So you've got the tray loaded, and you have to butterfly the tray into the patient's mouth. You butterfly it to keep the impression material from falling out. When you come over to the patient's mouth, you slip the loaded tray in the mouth. You hold it in position. The patient sticks the tongue way out, and then the patient starts bringing the tongue back to its rest position. Now, don't let the patient take the tongue back too far. The tongue should be right against the lower anterior teeth, filling the floor of the mouth, and then the patient brings the teeth together, and the lips come lightly together so that the peripheral tissues are at rest. To take an impression of a semi-dried, healthy ridge with the tissues in a resting state sets certain limitations on the impression material that we have available for use. So the requirements of an impression material have to be followed. The impression material must have tremendous flow properties. A material that has less resistance to flow than the tissues will not distort the tissue. The impression material should be compatible with saliva or moisture. Remember that the mouth is in a semi-dried condition. A zinc oxide eugenol material is compatible with saliva or moisture. In fact, the moisture helps the material set up after we get it in the mouth. It should have a controlled setting time. This material has a fast and a slow liquid that can be used to modify the set of the material according to the temperature, humidity, and the time that you would like. The ideal impression material would be one that you could mix properly, load the tray, place the tray in the mouth. As soon as it's in the mouth, if it would set immediately, this would be the ideal situation. So through the control of a fast and a slow liquid, we can vary the setting time. Now, it's good to make several trial practice mixes of the material until you're familiar with handling of the material. The material should set hard, and a zinc oxide eugenol material does set hard. We should set hard so we can put the impression back in the mouth, check the stability of the impression material, or the stable impression, before we make the base. Then the material should be compatible with the laboratory procedures, which would allow us to pour a refractory material into it or a stone model from which to make our casting. The material that we use that fits this requirement is the Ackerman's impression cement that is specifically designed for this procedure. It is a very fine mesh powder. It has tremendous flow properties. One of the difficulties in having material with tremendous flow properties is that it runs all over the place. You should protect the patient adequately with towels to keep from getting this on the clothing, and you should have yourself protected. I'm wearing rubber gloves now because this material sticks to the tissue if the tissue's dried. Now, the mixing of the material should be done on a parchment pad. Zinc oxide and eugenol liquid, or eugenol liquid will soak into a regular pad, so you have a parchment pad. Have a pad sufficiently large to accommodate the amount of mix that we would need. You need a wide spatula. The fine mesh powder makes it difficult to incorporate the powder into the liquid. So the first part of the mixing procedure is a pressing or a smashing of the liquid or powder into the liquid. To get an adequate mix, the manufacturer recommends a 2-to-1 ratio, a 2 powder to 1 liquid. You can use measuring cups such as I have here to estimate the 2-to-1 measurement. When you're starting out, this might be a good idea. However, once you get the feel of the material, you can estimate the mix of the material by putting a certain amount of the powder out on the pad and then estimating the amount of liquid you would want. From this, you would determine the stiffness or the consistency of the mix by how much powder you put in. So in this demonstration, I will show how we estimate it, and I prefer to estimate the mix. Paste the powder on the pad. Square it up till it covers about an area that's about a ½ inch thick. Then the amount of liquid that we pour out there would be an area equivalent to the area covered by the powder. Now, for routine conditions of temperature and humidity, we would use about 75% fast liquid and 25% of the slow liquid. So we'd pour out an area of liquid. That's the amount of fast liquid we need, and then we can pour out the 25% slow. And mix the two together. Now the patient should be ready. You can put a little Vaseline on the lips of the patient so that when you get the mix properly, you load the tray and then immediately go over to the patient and place it in the patient's mouth. The first part of the procedure, we try to incorporate as much powder as we can into the liquid. As you can see, it's difficult to get the powder to go into the liquid, so it's merely a smashing procedure at the time. First, get as much powder as you can into the liquid. Now, the beginning student generally starts out with too thin a mix. You're scared to put the powder into the mix. Once you think you've got enough powder into the mix, you want to dump off the excess powder off of the pad, and then you start the strapping procedures for incorporating and getting a nice, smooth, homogeneous mix. The more you strap, the more you spatulate, the thinner the material becomes. You want to get rid of the powder off of there so that you don't have streaks or unincorporated powder. When you have the mix properly spatulated, you gather up as much as you can, take the tray and load it in one continuous motion all the way around the tray. And then you've got to go to the mouth, get this to the mouth before it all runs out. And in doing that, to keep it in the tray, we would butterfly this over to the mouth, place it in the mouth. Patient, stick your tongue way out. Take your tongue back now. Toes together. Bring your teeth together. Right together. Lips together. And we allow that to set up. As we said, we like the material to set up as fast as we can. Probably takes 1 to 2 minutes for that to set, get the initial set. To check and see if the material is set, you can use a sharp instrument and see if the material is hard, and then you need to have the patient open, please. Now, to get the final set and to make the material real hard, have the patient rinse out a couple of times with some real cold water. Would you go ahead and take a sip of that water? And the cold water makes the material even set harder than it would be. Okay. Put your head back, please. Now we would have to free the impression from the teeth, and this would involve chipping away that material that's around the undercuts of the teeth. Now the abutment teeth we have loosened up so that they would come off with the impression, so there's no problem getting it out of the undercuts on the abutment teeth. So as we free the impression, the material, or the tray and the impression material should come out of the mouth. The first impression is generally used to tell where to trim the tray. Remember that we made this tray and estimated the peripheral outline from an overextended impression. The only way we can tell the relationship of the tray to the resting tissues is to take an impression. So we take the first impression, we use this to tell us where we trim the peripheries in relationship to the resting tissue. We can now evaluate this impression. We now examine the impression to determine whether we have the peripheral areas the way that we want and tell where to trim the tray. The things you'd look for in an accurate impression is to see that you picked up details. If you would look at this segment of our ridge, you can see here that we have picked up the fine details of the tissue covering the ridge. This would be the first requirement. And then what we'd like to have is the peripheries of the tray underneath the peripheries that the tissue is trying to trim. So as you see here, here's the periphery that is being trimmed in the mouth, and here's where the tray is. And this is an overextended impression. We'd want to trim that tray, so we'll narrow the tray in that area. Then we follow around to make sure we got a complete peripheral outline all the way around the impression. The tray is showing through a little bit there. We would want to reduce that, cut the tray back so that it doesn't show through. The periphery looks pretty good. It's showing through a little bit there. So we would mark that, trim the tray back a little bit. Now we would like to have the impression around the necks of the teeth. We can take these crowns out of there. We would like to save the area around the necks of the teeth so we can tell where to finish our casting. If we can get the crown out of there. We would like this area around the necks of the teeth so we can tell where to end our base casting. And we've picked up the necks of the teeth so we can tell where to position the lingual bar. We have a little void in the periphery area here of the lingual surface of the tongue. We have a large void over here that we didn't get enough material in that area to record the impression. This is a good impression of this peripheral area. So we come over here, this looks good, and here again our tray is a little bit wide, and we'd want to narrow the tray. So we would go back to the lab now and trim the tray back so that the peripheries of the tray will be under the peripheries of the impression. We will not attempt to wash this impression to secure a new impression, but we will tear out all of the impression material and retake the impression again after we've trimmed the tray. If you try to wash the impression, we would have a very close-fitting tray and a thin fluid in there. We would distort the tissue in trying to force the material out of the tray. So we'll now go back to the lab and trim our tray. The impression procedure from this point on is a matter of adding impression material and taking impressions and seeing if we get the accurate detail that we would like. Each time we would either have to trim the tray, we would remove all the impression material and retake the impression. Frequently, if it takes a long period of time, you may have to premedicate the patient with another atropine sulfate and get control of the saliva again. In this case, we took the second impression, and we are now going to evaluate that impression in the mouth. After the material has reached its initial set, it's well to go in there and examine the peripheral areas that you can see and see if they're okay. Open, please. Now roll your head this way just a little bit, please. This area here, tip your head down just a little bit. Examine the peripheral areas as you see here to make sure you got a good peripheral roll on that. If it looks like you have a void in that area, it is well to go ahead and add a little mix of the material right at this time. So you can correct the peripheries if you want to before you take the impression out of the mouth. So examine the peripheral areas that you can see. It looks like we've got a good roll on that area. Roll over to the other side, please. We look at the other side. Back along the tray, it looks like we've got a good roll right along the edge. It doesn't look like there's much material there, but we still have a good peripheral roll along the edge of that area. If there was a void there and you wanted to correct it, you would mix at this time, add it to there, let it set up before you take the tray out. We can now go ahead and take this tray out of the mouth, or the impression out of the mouth. Examine now the second impression, the areas that we trimmed the tray, and we find now that the peripheries are complete. We find the details of the tissue. This is a little bit overextended here. The tray is still a little bit wider than the peripheries, but yet we have a good peripheral roll all the way around the lingual area of the tray. So we have all the peripheries. We have the tissues around the teeth. We're very close on this impression. I would suggest that if you're, when you're taking these impressions, it might be well to have a couple of trays, or as we're going to do in this, it's not a perfect impression, but we're very close. What I'm going to do is go ahead and pour this up and then take another impression. You want to save the impression, one where you get quite close, because you may not get that close again. So I'm going to go ahead and pour this impression up and take another impression. After we have secured an accurate impression, the next stage is that we would like to check to make sure we have a stable impression. During this first part of this segment, I would like to take and explain what we mean by a stable impression, what we mean by a stable base. So we have a patient. To demonstrate this, we have a base that is completed. We'll show how we test the stability of the base, and then how we would use this to check the stability of our stable impression. So we will now demonstrate stability on a patient. Here we are going to record the details of the ridge in an undistorted condition, so that now when we make a base to fit this ridge in the resting position, we will have intimate contact of that base with the tissue when the tissue is at rest, so that when this base is put under function, we will not have any movement of the base. Or if any movement occurs, the only movement that could occur would be from compression of the tissue, if this does exist. So if we have our final base, we can check for the accuracy of the base. Here we have the final base. We can check to see if we have stability of the base by placing the base in the mouth. Go ahead and put that in, Wayne. With the base in the mouth, if it's a stable base, we should be able to apply a force on this side of the mouth and the other side stays stable. If we apply a force on this side and we have a movement of this base towards the bone because of a lack of detail or a compression of the tissue, distortion of the tissue, then the opposite side will raise up. So if we put something between the teeth, have the patient apply a force, we can observe the opposite side of the mouth to see if we've got any movement. Open again, please. Close. Would you bite on that, please? Open. This base should stay against the tissue. If we get movement of the base on this side, then this side should come up. With this graphic, we can explain why we would get movement of a base. If we distorted the tissue during the impression procedure, or we did not get the detail, we would have a base that would look somewhat like this. It would not fit the tissue at rest. When the base is at rest, the tissues have rebound and the base sits on the tops of the tissues. Now, when a load is applied to this side, this base would go towards the bone and the tissue until it reached a stable position. In doing so, the opposite side of this base would move away from the tissue because it's connected through the lingual bar. Now, when the force is released, the tissues would rebound again until they rested on the tops of the tissue, and then when another load was applied to this base, it would go towards the tissue and the opposite side would come away. And this is where we'd have an unstable base, and we could determine this by applying a force in the mouth and determining whether the opposite side would move away from the tissue. If we take an accurate, detailed impression of the ridge in its undistorted resting condition, and we make a base to fit this ridge, at rest, the base will have intimate contact with the ridge. It'll be resting against the tissues. An accurate fit where the tissue and the base are in intimate contact at rest. Now, when we apply a load to the occlusal surface, there is no place for the base to go. The tissue is in a resting position, in a position ready to receive the load, and therefore we wouldn't have movement of this base. In a stable base, we would not have movement of the tissue on this side, and therefore the opposite side would stay in place. So now if we apply a load to one side of the patient and we have stability of our base, we would find that the patient could apply considerable force to one side and the opposite side not come out. Apply the force again, please. Right hard. And we have here then a stable base which can support the occlusal load. If we understand these principles about what is involved in a stable base, we can start determining the accuracy of our base right at the time we take the impression, and that's why we term this a stable impression. We want to be able to check the stability of the impression the same way that we would the final base. So we would now use these principles to check this in the mouth. If we find that the impression is not stable, this means that we either not recorded detail, we've distorted the tissue, we would retake the impression until we have a stable base. So now we would go to the mouth, check the stability of the impression in the mouth. So now we have an accurate impression from looking at it. What we want to do is to place this in the mouth and check to make sure that we have a stable impression. We want to start verifying our stability right in the impression stage. This is why we like a hard material, as we can place this back in the mouth now, please. Open, please. Would you get the cheek retractors? What we do is we will seat this against the tissue and check for stability of the base. Would you hold this one? The stability we want to verify that is once we get the impression seated against the ridge, we can apply a vertical force on this side and this side will not come up. This side, observe this side. When we seat the impression against the tissue, we apply a vertical force, and you can see that we're applying quite a force. This side stays in place. That is stability, and this is what we want. Apply a vertical force on this side, and we'd observe whether the opposite side is coming away from the tissue. There should be no movement of that base away from the tissue. If we have this, then we can be sure we're on the way to a stable base. There are those who would still believe that the base has to move, that no matter what we would do, we would have a movable base. This procedure tends to eliminate those things that we have control over, and we feel that we can get a stable base. By the use of a bar graph, I would like to further explain why I feel bases have to move. If we have this bar graph, and we have a conventional base, what I call a conventional base, and our stable base, and we compare the factors involving these two. If we put into both of those bases the uncontrollable factors that we have, such as the natural occurring factors, there is some debate as to whether you can compress tissue or not, but let's assume that we can compress tissue a small amount. And we put this amount of movement into both bases. We might say we would have a small infinitesimal amount of movement of the base. However, in the conventional techniques, there are iatrogenic factors that the dentist has control over that contribute more to movement of the base than compression of the tissue. These factors are the distortion of the tissue during the impression procedure, as we have outlined in this procedure. This can give us base movement, as I have shown in the graphics throughout this procedure. Another factor would be a lack of detail in the impression procedure, as we have explained in this segment. Also, from sore spots, from movement of the base and so on, we would have probably base adjustments where grindings have been made on the inside of the base, and this would also add to an inaccuracy and base movement. We also could have base change over a period of time. This procedure, we use a metal base which stays stable over a period of time. Acrylics used in base materials can change with time. So there are a number of factors that could contribute to this movement of a base. These I have termed iatrogenic, and these the dentist has control over. So in this impression procedure, we have attempted, or this principles, we have attempted to eliminate all of those factors that we have control over. And we now have a base that is stable. The only possible movement that could occur in the base would be through the compression of the tissue. The tissue giving support to the base is in its natural contended positions, are not squeezed and are not tortured. They are not having to give and to fight back to their normal position. Possibly this is the condition where the tissue gives us a stable base, and also there is no need for this tissue to resorb. The tissue is in its normal, healthy condition. A more nearly physiological situation then is established in this procedure.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.